my topic will be on targeted therapy in esophageal carcinoma, especially in the surgically unresectable patients. So, first I'll give a short run through on esophageal carcinoma for the benefits of HOs. So, esophageal carcinoma essentially means carcinomatous growth of the esophagus. There are two predominant subtypes of this esophageal CA. These are composed mainly of adenocarcinoma and squamous cell carcinoma. Historically, squamous cell carcinoma predominates adeno-CA in terms of statistical prevalence. However, over the past few decades, we have seen an increase in incidence of adenocarcinoma. It is mostly due to patients having fewer smoking and alcohol intake and more obese related patients, because SCC's risk factor is mostly related to tobacco and alcohol intake, while adenocarcinoma is highly related to. So for the staging of esophageal CA, we usually go through either AJCC, which is the DNM staging, or the Japanese Esophageal Society staging. So basically what differs between these two is that JES is more of a grouping of the lymph nodes classification. This indicates on the difference between the local therapies such as hepatic therapy. So for the esophagogastric junction for adeno-CA, there's a special staging, which is a Seward's staging. So what Seward's actually shows is its distance from the esophagogastric junction. So there's three types basically. So this is the DNM staging for esophageal CA. So we have across T1 to T4 and from N0 to N3. M1 is basically a distant metastasis. So for esophageal carcinoma that is deemed as resectable, if they are indicated for esophagectomy, so here I've written these patients are usually CT1 to CT2, and if it includes some other lymph nodes, then patient might need some preoperative chemotherapy. Low risk lesions here, meaning it's the dysplasia is of low grade, and there are some other symptoms as well. So most of the thing about esophageal carcinoma is that most of the patients are diagnosed late stage. So we rarely meet all these P1A lesions that we could proceed with endoscopic resection. Otherwise, for the unresectable tumors, we give the option for definitive chemoradiation. So now on to my main part of this presentation, which is targeted therapy in non-resectable patients. So targeted therapy is actually different from chemotherapy and also immunotherapy. Usually the thing that we see in what is actually chemotherapy. It differs usually from targeted therapy in that the agent that we use is different. Chemotherapy mainly targets actively dividing cells, while the agents of targeted therapy mainly targets proteins required for cancer growth. So macam all those fluorouracil, capecitabine, semua tu it only attacks the rapidly dividing cells. So in these patients you would see all those side effects involving those rapidly dividing healthy cells, macam unhealthy mucous membranes and all. So for this targeted therapy, one advantage that we could see over the chemotherapy is that patients are generally more tolerable towards targeted therapy. And for immunotherapy, agents used in targeted therapy are generally more cheaper to make and much less expensive as compared to agents used in immunotherapy. So in Malaysia, once patients is diagnosed with esophageal carcinoma, the histopathological diagnosis would suffice as to the grading of the cellular dysplasia. Rarely do we assess for some of those immunohistochemical staining. So from this guideline from 2019 of the Oncological Conference, they actually suggested for HER2 positivity and also MIS, which is a microsatellite instability, and also PDL1 expression. So HER2 implicates the next treatment for targeted therapy, which I'll explain later, and also patients with HER2 positive. HER2 positive is usually on patients with adenocarcinoma. It can also be used for prognostications, in which these patients who are HER2 positive have much poorer prognosis. Okay, so if patients who are HER2 positive, they recommend the usage of Transtuzumab or Herceptin. In Malaysia, we use Herceptin for breast carcinoma and gastric carcinoma. In KKM, we use for breast CAs, but actually we don't use it for gastric CAs. We use Herceptin for gastric CAs in private setting. So what Transtuzumab actually does is it targets the HER2 receptors, and this HER2 receptors is actually an important ligand for protein synthesis. They actually recommended this Transtuzumab as an addition to a first-line chemotherapy. Here, one of the few studies showed that Herceptin showed some overall survival rate of much more than given the first-line chemotherapy alone. Also, for Herceptin, there does not seem to be any difference in rates of neutropenia and neuropathies. So, generally speaking, the safety profile is there. Next, we have Ramucirumab and Pembrolizumab. So, Ramucirumab is a VEGFR2 antibody. This is actually much more expensive than Herceptin. So, Ramucirumab is also a choice of targeted therapy, but this is used in as second line for an additional agent for chemotherapy. And also we have Pembrolizumab. Apparently, Pembrolizumab is not, if I'm not mistaken, is not widely used here in Malaysia. But all of these three drugs are FDA approved. So what basically this study shows is that Transtuzumab plus chemotherapy is recommended as first-line therapy for patients with HER2 positive metastatic adenocarcinoma. So what they actually suggest is that for all patients who are suspected metastatic adeno-CA, they suggested to also test for HER2. But I understand we don't routinely test for HER2 for esophageal CA here, because for testing of HER2 costs around 550 to 700 ringgit, and we don't even do it here. We send these HPs to Ipoh for them to do. Other than that, Ramucirumab and Pembrolizumab is recommended as an inclusion for second-line therapy. So I hope within the next few years that this guideline can be used as a mode of treatment for patients with esophageal carcinoma, because now not much options are given to them. Okay, that's it for my presentation. Are there any questions?